Hi, Mr. Corvus.
Yes.
My name's Taylor Triana. I'm a medical student. It's nice to meet you.
Hi, nice to meet you.
This is Dr. Spickard.
Hi, sir. Hi, nice to meet you. Good to see you.
I understand that you've been feeling poorly, so I'm going to go ahead and examine you and talk to you about your symptoms, and Dr. Spickard is just going to be here watching us, okay? I'm going to take a seat here. So, Mr. Corvus, what brings you in today?
Just feeling like some symptoms of like a cold coming on.
Okay.
Last couple of days.
Okay, a couple days.
Yeah.
What kind of symptoms?
Started out with a sore throat.
Mm-hmm.
Now, woke up this morning, had a little bit of drainage, some congestion.
Okay.
Sneezing a little bit.
Okay. Have you had any fevers?
No fevers.
No. Okay. Anyone at home sick?
No, just me.
Okay. Anything else going on? Any medicines?
I took some Mucinex this morning.
Okay.
That's the first thing I've
Mucinex. Did the Mucinex make you feel better?
taken. A little bit.
Okay. Okay. Have you had any trouble swallowing or eating or drinking?
No.
No.
Yet.
Any changes in going to the bathroom, bowel movements,
No.
diarrhea, constipation?
No.
Okay, so I'm hearing that you've had some cold symptoms for a couple days, no medicines really, no fevers, but you took some Mucinex and that made you feel better.
Yeah.
Okay, great. So I am going to go ahead and move on to the physical exam. So Mr. Corvus, if it's okay with you, I'm going to go ahead and examine you now.
Okay.
I'm going to start by feeling your neck to see if I can feel any lymph nodes. Any tenderness or pain when I'm doing this?
No.
Okay. Next, I'm going to take a look at your throat to see if you have any redness there. Can you say ah for me? Ah. Good. Smile. Okay. Can you lift up? And I'm going to look inside your nares. Good. And now I'm going to have you just look at me so I can look in your eyes. No redness. Very good. I am now going to take a quick listen to your lungs, okay? Do you mind if I untie the back of your gown so I can listen to the back of your lungs? Thanks. Deep breaths for me. And then one more. Good. Your lungs sound clear. I'm going to take a quick listen to your heart. I'm going to have you lay back a little bit. Let me lift this up for your feet. Okay. Do you mind if I pull down your gown right here?
Sure.
Great. Okay, your heart sounds good. Okay. I'm going to take a quick feel for your pulse. And any abdominal pain, did you say that already?
No.
No? Okay. Sorry to keep asking you all these questions. Okay, you can go ahead and sit up now. Okay. Now I'm just going to tell Dr. Spickard what I've learned about you in our quick conversation and exam. So Mr. Corvus is a 38-year-old male, and he presents with a couple days of congestion, feeling kind of bad, no fever, no sick contacts, and really no other symptoms, just feeling crummy. He hasn't had any fever, he hasn't had any changes in bowel or bladder. His exam was largely benign. HENT was negative. He didn't have any erythema in his throat, no lymphadenopathy, no tonsillar exudates. His nares were patent, and his eyes also looked great. No redness, no conjunctival injection. Cardiac and pulmonary exam were also normal. Anterior lung fields, I did listen over his gown because I didn't want to bother him too soon in the exam, but they were clear. His His lungs and his back were also clear. I didn't hear any consolidation or crackles or rhonchi, and his cardiac exam was normal. So to summarize what I think is going on, Mr. Corvus has some symptoms that are really similar to a common cold. It is November and a lot of people have colds this time of the year, so I think that's one possibility. But it has been going on for a couple days. So it could be something more serious like a pneumonia or like a sinus infection, maybe even some kind of eye infection or deeper infection that hasn't manifested yet. So I am a little bit concerned about those things. But he looks pretty healthy, and I don't want to bother him too much with the exam right now, but I think we've done most everything. So I think this is a common cold. I think that Mr. Corvus can go back to work, and if his symptoms worsen, if he gets fever or if he starts having vomiting or diarrhea or coughing up anything, then I would be more concerned and I would ask him to return to the doctor.
Okay, thank you very much. Mr. Corvus, thank you for letting us come to work with you together. We're going to step out and chat a little bit more, and then Taylor will be back in to talk with you a little more. Okay.
Thank you, Mr. Corvus. I'll be back shortly.
Okay.
So Taylor, how did that go for you?
I think that overall it went well, but I felt like my history was a little bit unorganized, and I wasn't able to figure out what questions I wanted to ask in the moment, so I was kind of jumping around.
Okay.
With the exam, I forgot about taking off the gown in the front, so I know I made a mistake there, and I think I jumped a little bit too quickly to serious infections, and I may have scared him a little bit.
What if we were to step back and just marvel at the fact that you came in here and in just a short period of time took a brief focus history and an exam and came up with a very reasonable diagnosis and plan that I think put the guy at ease. And in a way, it's exceptional that you guys are doing this so early in your training.
Well, thank you.
Yeah, I mean, I'm celebrating that.
Thank you.
All right, so we can step back and deconstruct it and talk about those things.
Okay.
Because those are good points, and I'm pleased that you have some awareness of those things. So I love how you introduced me and kind of set up the encounter. Then the next thing you did was ask him why he's here and got from him the narrative. Then what happened in your brain, do you think?
Then he told me he had been feeling sick, so I started thinking about other patients that I had seen recently that had come in with those similar complaints.
Sure.
And I have been in clinic lately, and it's November. A lot of people that I've seen have been coming in with colds. I saw one person with a pneumonia, so I jumped to some of the recent experiences that I've had.
Sure. And what I see when that happens is something that happens, it seems, with all of our histories, where we are listening, we are gathering the nature of the case, we're determining, what kind of case this is, and then all of a sudden, what do? We start thinking,
It all started piecing together a little bit.
Exactly, I have an agenda. Now, if we knew the patient had an asthma exacerbation, it was obvious, they have a history of asthma, they're wheezing. It may not be that the agenda is the differential as much as why did this chronic disease get worse, or how bad is it for the patient, and those things are obvious agendas. The most common one that we're all excited about, especially as students, is the differential, right?
Right.
So I noticed that you didn't have any paper, and you were doing this well, but from memory, and I might make a suggestion.
Okay.
And this is the following. Notice that point during the history where things come from the patient giving you information, that all of a sudden it kind of switches, and all of a sudden I have an agenda and I have some things I need to do, or need to determine. And often one can be helped by just writing down the differential.
Okay.
Literally, it's not that you have to write every single thing. At your stage, being more of a senior medical student, you are able to hear and remember. But one is not so disruptive to that flow, in my view. If you were to say, like URI, flu, and that makes you think of the vaccine, allergic rhinitis, you think about the history of that and whether they've had this before and they've had medicines, and then of course the big things like pneumonia and things like that. And sometimes when I have those things written down and just looking at them, it helps me know that kind of moving through my agenda.
Right.
And it doesn't mean that I'm writing every single thing down.
Okay.
But it does help me, especially with that place where you're kind of, how you and I feel like we're not sure we're done.
Mm-hmm.
Is it time yet for the physical, or
Right.
is it time yet for the past history? Or in these brief encounters, how much of the past history do we need?
Mm-hmm.
And so those kinds of things can direct your questioning. And what I call that is allow the differential to guide your questioning. Does that
Okay.
make sense?
That makes great sense. Thank you.
I thought you moved through the physical exam well. Agree on the idea of the gown, but it was key, that, of course, that you listened to the skin on the back with the lung exam. Now, many of us were taught to examine the patient from the right side of the patient, from the patient's right side. Do you have any idea why that would be? Have you heard that before?
I have heard that. I thought since all the tools were on this side, it was easier for me to just stand on his left side.
So I'm gonna make up a big point, and
Okay.
I hope I'm not exaggerating.
Okay.
Okay, ready? Who's the most important person in the room during the physical exam?
The patient.
You would think it is.
Me.
Yes.
I'm the most. I didn't know that.
It's a trick question.
Okay.
Of course, the patient is the most
Uh-huh.
important person. In order to make that person the most important person, we need you to be able to do it the very, 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 very best, right? And so there's a tendency to kind of work with the positioning of the patient. Of course, one can examine from the left side, but we're very encouraging of all you guys to get set in your ways and to learn how to do the nuanced things the same way every time.
Okay.
Much like learning to play a sport, and maybe I'm a tennis player, learning to play with a two-handed backhand
Right.
instead of a one-handed, and stick with it, and not interchange it, if that makes sense. And that's an exaggerating way of doing it. I'm left-handed, for example, and in med school, I remember being on the patient's right side. I was really having to learn how to be, fairly agile in the micro management of my hands, and that was a learning curve for me. So the point is this: as you are developing your style, I really encourage you to get it the same way every time, and that way you get good at it.
Okay.
That way you're deciding what is the best position in which I get the most information. I learned for a long time ago that I get better information from me in the way I learned by doing the neck exam, for example, from behind the patient. Totally affects the way that I set up the room to
Right.
make sure that I have a chance to stand or sit next to the patient to their
Okay.
right. So that's just a suggestion. And then the last thing I will say is, as you get really good at each of the features of the exam with that practice, you'll find yourself not wanting to say the word quick.
Did I
Why-
say quick a lot? Okay.
It's very common to do that. Why do you think we do that?
I think I get nervous about taking up
Yeah.
too much of the patient's time because I'm the student. Everyone else has already seen him.
So the process of your development is to believe that you're becoming increasingly amazingly valuable,
Okay.
that you absolutely are where you need to be and are validated to get the room set up the way you want, to not worry about how long it takes, and to know between you and me it is going to be quick. And I got rid of that word a long time ago for the same reason. And although in my mind I know it's quick,
Right.
I'd rather say this: we're going to do a physical exam. I'm going to choose certain features of the exam to engage today based on this presentations. The ones that I'm choosing to do end up being only a few, and they are going to be doing really well. And oh, by the way, it's going to be quick.
Okay.
But we don't want them to think that they're
Right.
being shortchanged.
Okay.
If that's fair. Is
Yeah,
that fair?
That's great advice. Thank
Okay.
you.
Good. I think you should realize, as we started, that you have walked in the room, you've assessed a patient in about 8 minutes. I think you got the diagnosis right. You have a treatment plan. You have a follow-up in case it doesn't work. And I didn't say a word. Isn't
Well,
that great?
thank you. I did have 2 quick questions for
Okay.
you, though. I was wondering what other parts of the exam you would have done.
Fair enough. Not any others.
Okay.
As I think about it, he did not have ear trouble. He did have eye trouble, so I might have looked a little more thoroughly with the eyes,
Right.
the eye exam, to determine about conjunctival injection. but I was listening for ear or anything related to meningitis to
Right.
think about subtleness.
And he didn't have any.
And of course, there wasn't pleuritic chest pain associated with it to think of any reason to hit on the back
Right.
that would unearth something that was musculoskeletal and not pulmonary.
Okay.
So I was thinking and tracking with you, and,
Okay.
and I think you did a good job of what you
Okay.
chose to do.
And then the thing that I want to do some research on, finishing up this MCT, is looking at different ways you can manage the common cold. And I know a lot of doctors give antibiotics for a common cold, so I want to just do some research on when that would be appropriate, if ever, and know more about those guidelines.
Right. Let's hear back from you about that. That would
Okay,
be fun to do.
great. I'll shoot you an email in the next couple of days
Sounds
then.
great.
Thank you.
Good job.
Thanks.